Lorsque votre santé devient une priorité, chaque détail compte, chaque minute compte et chaque décision compte. Au siège de Homecare Head Office ici à Eben, nous mettons à votre disposition une équipe engagée et professionnelle, entièrement dédiée à votre accompagnement médical vers la Grande Péninsule, l'Inde. Nous organisons vos consultations avec des établissements de renom en Inde. Tout cela en assurant une coordination précise et efficace de votre dossier, ici même à Eben. Dès votre premier contact, notre équipe vous accompagne étape par étape. Analyse de votre dossier, orientation vers les services spécialisés et bien sûr, un suivi constant et assistante permanente. Visa médical, formalités administratives, documentations officielles, nous gérons l'ensemble des démarches pour vous permettre de voyager en toute sécurité. N'hésitez pas à nous appeler sur le 490 0210 pour tous vos rendez-vous. Lorsque votre santé devient une priorité, chaque détail compte, chaque minute compte et chaque décision compte. Au siège de Homecare Head Office ici à Eben, nous mettons à votre disposition une équipe engagée et professionnelle, entièrement dédiée à votre accompagnement médical vers la Grande Péninsule, l'Inde. Nous organisons vos consultations avec des établissements de renom en Inde. Tout cela en assurant une coordination précise et efficace de votre dossier, ici même à Eben. Dès votre premier contact, notre équipe vous accompagne étape par étape. Analyse de votre dossier, orientation vers les services spécialisés et bien sûr, un suivi constant et assistante permanente. Visa médical, formalités administratives, documentations officielles, nous gérons l'ensemble des démarches pour vous permettre de voyager en toute sécurité. N'hésitez pas à nous appeler sur le 490 0210 pour tous vos rendez-vous. Lorsque votre santé devient une priorité, chaque détail compte, chaque minute compte et chaque décision compte. Au siège de Homecare Head Office ici à Eben, nous mettons à votre disposition une équipe engagée et professionnelle, entièrement dédiée à votre accompagnement médical vers la Grande Péninsule, l'Inde. Nous organisons vos consultations avec des établissements de renom en Inde. Tout cela en assurant une coordination précise et efficace de votre dossier, ici.
Mesdames, Messieurs, bonjour, bienvenue dans ce direct. Nous sommes ravis de vous accueillir de Homecare Studio à Kirby. Bon appétit si vous passez à table. Donc, c'est un moment très important qui nous envie partage avec vous aujourd'hui. Qui fait, nous peut faire ça direct là, comme indiqué dans le titre. Donc, nous sommes avec nous sur le plateau de Homecare Santé Plus à Kirby aujourd'hui. Un sommité dans ce domaine dans la Grande Péninsule en Inde, le docteur Anant Kumar, chairman of the Renal Transplant Unit, if I may term it like that, at Max Super Speciality Hospital, India. Nous pouvons aborder plusieurs aspects, plusieurs questions que nous pouvons poser pendant cette émission-là. Donc, ce sera une émission que nous pouvons demander aux téléspectateurs et aux internautes de suivre avec beaucoup d'attention parce qu'il y a beaucoup d'informations à retenir. Première chose qui nous peut faire ressortir, c'est qu'il nous félicite le gouvernement mauricien qui fait une lance hier en présence du ministre des Affaires étrangères indien, le docteur Jaishankar, à Rosebell, ensemble avec Dr Navin Ghulam et Anil Bechu, ministre de la Santé. Je fais une lance un Renal Transplant Unit à Rosebell, l'hôpital Rosebell, pour faciliter justement les patients qui gagnent problème rénal, qui est là pour faire dialyse ou bien qui est là pour faire une transplantation rénale. Donc maintenant, il est possible pour faire une transplantation à l'île Maurice, mais les faits lancés et étant toujours un protocole à mettre en place si mon papé faire erreur. Donc nous sommes en studio avec nous Dr Anant Kumar de Max Super Speciality Hospital, Chairman Urology, Renal Transplant, Robotics and Uro-Oncology. Nous pouvons faire sa partie l'émission là en anglais avec Dr Anant Kumar. Good morning.
Good morning.
You just came off your flight and
Yes.
you are already in Omka studio. It's very, very important that we talk about your specialty, urology, renal transplant, robotics, and uro-oncology. Uro-oncology, if we term it like that, how would you describe to people what is uro-oncology?
Yeah. Thank you for inviting me to this studio.
You're welcome.
This is a great opportunity to interacting the people from the Africa and Indian Ocean and Mauritius and around that. And I'm very happy to know that OMCA is doing great job and helping the people to get right treatment. So uro-oncology is a branch where we treat all the cancer inflecting in the urological system. The urological system constitutes of kidney, ureter. Ureter is a pipe which drain urine from kidney to the bladder, urinary bladder where urine is stored, and then it come out through the penis and urethra and the testis. So there is a lot of cancers develop, especially like in young age, they develop in the testis. And testis cancer in last 30 years, very good advancement has occurred that it is curable. And it happens in young age, so they get a operation and then chemotherapy and they are cured for life. And then especially in penis, the cancer is common, especially in poor population and African population. It is all related to the poor hygiene. Of the penis, and they develop penile cancer, and which is very bad cancer. If not treated in time and properly, can cause problem.
Sometimes we do have this saying that cancer, whatever cancer it may be, if detected earlier, it's like 80% that you can
That's
save.
a very true statement. That's why it is important to prevent. First thing, prevent the cancer. It should not happen. But if it has happened and picked up in early stage, then it is almost curable. So other cancer, uro-oncology, very common cancer is bladder cancer.
Yeah.
It usually happens because of the smoking. Is very bad and it causes bladder cancer. And then the kidney cancer is also very common. And nowadays the advancement has occurred, especially in kidney cancer, prostate cancer, and bladder cancer, that most of the operation is done with the robot. Like prostate is the most common operation. Prostate is a gland situated just below the bladder, which secretes lot of secretions which comes out and nourish the sperms, which is stayed in seminal vesicle. And it's got a lot of good, and at the age of 50 it start growing.
Yeah.
And at the elderly age, a lot of people develop cancer in that. And it is situated in such a remote area in the pelvis, because I have done more than 400 open operation. It used to be very difficult operation
to access.
because it is to go there, and sometimes we used to feel and do the operation. And with the robot, your camera goes there. We see everything in 5 to 10 times magnification. Our instruments go there and do the operation. So the prostate operation has become so simple. No blood transfusion is required. Patient is discharged after 24 hours. They have good urinary control, and some of them have a good sexual function control if their nerves are preserved.
Yes.
So that whole scene has changed of prostate cancer. Same way bladder cancer used to be very big operation, and the bowel related complications are very much, because the handling the bowel lead to paralytic ileus. It means patient will not pass gas and motion for few days, and his abdomen is bloated up, and they are very
Feel very
painful
uncomfortable,
situation. And because of that, sometimes the bowel we have joined also leaks. So the bowel complications were very high. But with the help of robot, operations are done. We make artificial bladder, or we make a opening in the abdomen from where you can come out. Both operations are done with the robot without opening the abdomen. And the patients are back home at 5 to 7 days, and bowel complication has gone down. Results are very good. Cancer control is same whether you do open operation or the robotic operation. And there is a lot of development in kidney cancer. Like 30 years, 25 years back, if there is somebody's kidney cancer, whole kidney was removed.
Yeah.
But nowadays, unless kidney tumor is too big, like 8-9 centimeter and involving most of the kidney. Don't remove kidney. You remove the tumor, save the kidney, so that because kidney is a very important, makes urine, take out all the toxic product from your body. So we remove the tumor with 1 centimeter margin. So that cancer control is as good as you remove the whole kidney. And we save the kidney. So that kidney function is very good. It has been seen if you remove whole kidney and your kidney function is not good, you develop more heart-related problems.
Yes, you can have cardiac
So cardiac events also. So this is a major development by doing robotic partial nephrectomy, robotic nephrouretectomy, robotic cystectomy and neobladder, radical prostate, and testicular tumor, retroperitoneal lymph node dissection, and penile cancer, inguinal lymph node dissection used to be done open. It was not a difficult operation. But since you remove there is a flap necrosis, and lot of morbidity, patient used to undergo dressing for 6 weeks. Nowadays, the whole operation done with the robot, patient is discharged next day, and they do have a drain which stays for a few days, maybe 2 weeks.
It's minimal invasive.
And then all the morbidity and complications have gone. And you can see and so lot of blood is saved. Patients are going home quickly. They can go back to work quickly. They don't get wound infection. And they get similar cancer control, whether you do open operation, whether you remove the whole kidney, whether you remove the part of the kidney. So in a well-selected patient, properly done operation, robot has changed the whole world. And now it's not only in it is not a fashion, now it has become a necessity. And more than 15,000 robots are there all over the world, and more than 10,000 doctors are trained in a robotic surgery. And last year the figure is 21 million people have been treated with the robot.
With robotic
so you can see that it is not that hype. It is now the requirement, necessity.
It's the new requirement.
New requirement because it improves the quality of life.
And maybe the doctor's job also, the surgeon's job also is made very easy.
And we sit down and we do the operation, and our tremor is not there. And we sit in a work and relaxed position, and our all movements are. It is a master and slave device. It's not that robot is doing operation.
You are doing the operation.
We do the operation, but the robot is helping us to do it in a very precise way and going very close to the lesion.
We may say that it reduces human error.
It reduces human error. If you have tremor, like a lot of people have tremor, especially those doctors who smoke, or those who develop some disease, and then their hands are shaking. So they can't do. But here all your tremor will be filtered by the robot. And robot will be doing very precise. So you mark it and it will just do the work.
Some 20-25 years back, if someone would tell you that robotic surgery will be the future of treatment and global healthcare, how would you have responded to that?
People were laughing at that time. Because the reason was, at that time laparoscopic surgery has just come up. And laparoscopic surgery was like minimally invasive. But the problem in laparoscopic surgery, it is a 3-degree movement. And robot has 7-degree movement. 7-degree movement. And rigid, and that laparoscopic were rigid instruments. So in America, they call it stick surgery.
Stick surgery.
Because they're like a stick, you are doing it. But the robot is like moving arms and everything inside.
It can rotate, and as you said, 7 degrees of movement.
And then a lot of criticism was the robot was very expensive. It is still expensive. But in long run, it has shown that if you do the operation, complication rates are less, patients are discharged early, hospital beds are saved, and a lot of consumables are saved. So its cost is compensated by other outcome and less complication and other things.
And also your population is healthier, and people can be treated much.
And all the people who were criticizing robotic. And they were very good laparoscopic surgeon at that time. They all changed. Now all are doing the robotic surgery.
They shifted to... Same thing maybe if today people will say that AI is taking over on...
life is evolving. Things will change.
It will keep on changing.
It will keep on changing. What is today, I'm saying that may not be true after 25 years.
Of course. Of course. How did you manage this transition from being
Yeah,
this?
so
Was that difficult?
no, it's not. I'll tell you, it is very interesting. We like to accept the challenge,
Yeah.
and we like to take it. Because you won't believe, when I was trained in 83 to 85 in urology, at that time, only endoscopic procedure was cystoscopy, optical ureterectomy, TURBT, and TURP.
That's it.
That's all. And all surgery was done in open. Then came ureteroscopy, like you can go and take out the stone through the ureter. Then came the percutaneous nephrolithotomy, like making a small puncture and take it. These were all, and whatever came, we started learning. And then came the laparoscopic surgery. Then we learned laparoscopic surgery. Then came the laser surgery. So we learned the laser surgery. Then came the robot. So it was a challenge, and we enjoyed learning it. It was a struggle little bit, but now we enjoy it that we did the. So I take it a challenge, and any new things comes, and I keep reading what is new coming, and I keep going to the international conference and watch the people go to the big American hospitals, watch all the big people are doing, and then we come back and start doing it because we have a patient, we have a technology.
You need to
so
develop
we
it.
very soon will be doing the same thing, and sometimes we do better than them because we have large number of patients to practice.
Of course, and the volume of patient that you
Volume
have
of the
also
patient
is-
gives good experience. So we
Of
are
course.
thankful to our patient
of
because
course.
we have large number of patients. So we learn very quickly, and then we provide good results. That's why some of the American surgeons, when they come to our center and they watch, they are very surprised that we are doing such a good work. Now, Indian surgeons, like I have gone to do the surgery in Europe and in Japan, and we go as a proctor to teach them.
Yeah.
Because like robotic transplant, we have done maximum number of robotic transplant in the world. No single center has done 500 cases, which we have done.
Yeah.
So I've been invited to in Tokyo to go and train their doctor there. I was invited to Switzerland. I'll be going to England, and we have gone to many other countries for various workshops, showing our work. So we are
And displaying
invited to
all
publish
this.
our things. Some of the things which we have published was never done before, like extraperitoneal robotic transplant. So it's a challenge, and we have all the resources. We have a technology, we have equipment, and we have a lot of patients. So we are fortunate that we quickly adapt to the technology. And nowadays, because of the communication and because of the such a good communication network, we can interconnect with our colleagues, and if any problem, take their opinion. A lot of people call us for problem, and we tell them. And now we're going to be possible to do robotic proctoring without going to the other centers. So all these things, new technology is coming.
You may be sitting in India and
And
performing
and helping
surgery
the people in Mauritius.
in Mauritius or in Africa.
Yeah.
One thing that we talk about just before we started this interview, you talk about some African patient coming to you most of the time. You told me that most of them comes to you with a enlarged prostate. How important is it to have to treat people in order for knowledge to be expanded from different genetic pools?
Yeah, so one thing like prostate, all men have prostate gland, which is like a walnut situated under the bladder, around the urinary passage urethra. And for some unknown reason, after the age of 50, it will keep on growing, enlarging, and it will keep on doing till you meet the God. It is like aging process.
Yeah.
Some people get affected by this, others do not. And I'm surprised to see we have patients come from Middle East and Africa. They have a very large prostate. Indians don't have large prostate. And some have 200 grams, 300, 400, 450 grams. That is not unusual.
Yes.
And such a big prostate can, before the robot came, it was only done by open operation. There was no way you can do it endoscopic procedure.
Endoscopic, yeah.
And then they have a lot of complication, urinary leak and urinary incontinence, bleeding. Some of the people used to die because of blood transfusion. And with this robot, operation has become so simple. We can go into the bladder, remove everything, reconstruct everything. bleeding stops on table, no blood transfusion is required, patients are discharged next day, and catheter is removed between 5th and 7th day, and there is no stricture, good continence. And I found that this is a very good operation for the benign enlargement of the prostate, especially for people who are big. And I don't know why Indian prostates are not very big, but that people coming from Africa and Middle East, they have a very large prostate.
Maybe, doctor, we can shift now from uro-oncology and we come to the Mauritian audience. Most of us, plusieurs d'entre eux à l'île Maurice qui peut get nous. Let's come to the Mauritian patient. Most of the people, Mauritian, the availability of their treatment, like regarding kidney transplants or advanced kidney diseases, chronic kidney diseases, we don't have that here in Mauritius. Or if we do have it, it's something not reliable that we can. Most of them make the choice to go to India and get their treatment there. How do you manage treating international patients?
Yeah, so I think this is a very good question. I would like to, at the end of that, I would like to make some suggestion also. See, we get kidney transplant patient from, we do around 350 kidney transplant every year. And we get all kinds of patients, 3-year-old baby to 70 years old man. First transplant, second transplant, third transplant, ABO incompatible transplant, sensitized transplant, failed transplant. We get all kinds of patients. And we have been doing for last 40 years. I myself have done more than 5,000 kidney transplant by now and 500 robotic transplant. And so one thing is that we have all the infrastructure. We have a very good nephrology department, very good multi-specialty department. These patients are sick. They not only have kidney disease, they have heart disease, they have lung disease, they have liver disease,
diabetes,
hypertension. So we have to need the help of cardiologist, gastroenterologist, neurologist, nephrologist, everybody to pitch in and make the patient better before we operate. So one thing is that do operation, and we all international patient, we insist that you are discharged on 6-7 day, then you stay at least for 6 to 8 weeks, because in first month is very vital. We make sure that their kidneys are doing well, there is no rejection, their drugs are optimized, and then they give all the instruction to go home. Now, only doing operation is not enough. Good follow-up is very important for success of kidney transplantation. And I have seen that some of the African countries, like tacrolimus level is not available. Some of the Central Asian countries, these tests are not available. And there are not many doctors who are trained in treating kidney transplant patients. So they go back and then they are not being cared of, and they also start doing, they forget about it. Sometimes they miss the medicine. Most common cause of poor kidney function is the poor compliance. Patient is not taking medicine regularly. That's why I always tell patient, you may forget taking food, but don't forget taking your medicine. Because if you miss for 2 days, you'll get a rejection. So keep an alarm in your phone and keep taking your medicine. So when they get into the problem, then they talk to us, and it is not easy that you just fly. They have to get visa, and then they have to organize finances. And by the time they reach it, sometimes kidneys are gone and we can't help it except take care of their complication. So what my suggestion is that nowadays there is a good communication system everywhere. And I would love to spare time and to do video consultation for such patient in each country. And I would like that each country should identify a trained person. So patient can go there, get the test done, the doctor sees them, then the doctor can send us through the email all the problem. This is the patient condition, these are the tests, these are problem I feel and what we should do it. So we go through it, and then we set up within 24 hours, we set up a time, especially in the evening, once our work is over, and do video consult. Teleconsultation. At least we can guide them. That you do this thing, check these things. If that comes, then you do this. If this comes, then you do this. And we can also tell that this probably patient should come back to us as soon as possible. Meanwhile, you take care of these things. So at least the help is provided, patient gets good care. And even if we are sitting with the help of teleconsultation, video consultation, we can see the patient, we can see all the reports, we can tell it. Then patient can provide, and it will be very satisfying that you have done a complex surgery and now patient is doing well. So I'll be happy to do, and I have suggested, and I also, we have done it. We have trained the person from Kenya, from Tanzania, from Uzbekistan, from Afghanistan, from Iraq. We have trained the doctors. We said, send your doctors. We'll train them.
You train them, and then
So they stayed with us for 6 months. They knew everything. So they know how to manage this patient. They gone back. So any problem, we tell them, give their number. When you go back, contact this doctor. So he will help you and he will guide you. And then those doctors are doing great job.
Yeah.
They are just identifying the problem, are communicating with.
And then they connect.
And
to
I
you,
always say send the mail, because I check all the mail and all the message morning, evening, because daytime I am operating and doing other things. And then I reply to them and then tell them get these things, and then and then they set up some video consult with the patient. Patient also get satisfied.
Of course.
He
they
also
get
sees
this-
the same doctor and listen to that. So that I will be happy to do it. And
This is what we do here at UMCA. When we started UMCA, one of the first thing in Mauritius that we can say that we are a pioneer is teleconsultation. We bring our patients here, and then they talk to our doctors in India by video consultation. One question I would like to ask you, doctor, is I've got this question from many people who ask me to ask you this question. Most of the people going for kidney transplants, can you explain to them how these immunosuppressive drugs work after the kidney transplant, so that we don't have any rejection in this? Because we do have one patient right now at the foundation, UMCA Foundation. He's going for his second kidney transplant. He did one 3 years earlier, and after 3 years, rejected. They want to know how does this mechanism work, so that they can understand it and preparing them mentally before they go for a kidney transplant. How would you describe that?
yeah, that's a very good question. One is that is immunosuppression. Before we do transplant, we check all the compatibility between donor and recipient. And once their cross match is negative, only then we do the transplant. Even after all that checking, if the patient has same blood group, 10% of the people will develop rejection. It means 90% are doing well. Only 10% are getting problem. And in the same blood group, still 10% people get rejection. Whatever you do, it will happen. Out of 10, 7 can be salvaged by treatment, anti-rejection treatment. 3 may not be. But if you are doing ABO incompatible transplants, then 20% patient get into the problem. And out of 20, 10, 12 will not be salvaged. Because there you get ABO incompatible rejection, antibody-mediated rejection. And that's sometimes very difficult to treat. So
This is when we go by plasmapheresis.
Plasmapheresis and
then
rituximab and euclizumab and a lot of other things. So my first advice is, what you can do is that good compliance. Most common cause of rejection is poor compliance. People start feeling good, they start eating, and they forget to take the drug in time. I always tell everybody, you may forget, take your food, but don't forget to take your medicine. Put an alarm and take the medicine. In case you forget, as soon as you remember, take the medicine. Even if it is like a double dose, doesn't matter. Suppose you are not sure whether you have taken medicine or not. Take again. At least it will not harm you that much rather than missing the dose. And the most common cause of rejection is people miss. They lie. They don't tell us that they miss the dose. Sometimes they miss it for 2-3 days. Sometimes medicine is not available in their country.
Yeah.
And then they can't help it, and then they get rejection. So I always tell that in case you are getting medicine, let us know. we will see what we can do to provide the medicine there.
We do have this problem here. We encounter a lot of patients saying that they went for a kidney transplant and then maybe for 2-3 months the medication is not available here in Mauritius, and they come to us to go look for the medicine in India and bring to them. One of the questions that most of the people maybe would ask themselves if they are watching us today, you get your kidney transplant done. Maybe it's compatible or maybe incompatible. You get the kidney transplant done. What you said, the compliance is very important.
Very important.
Very important. You said you may forget to take your food, but don't forget to take your medicine. What about the food? What should people eat after kidney transplant?
Before I go, there is one more important thing.
Yes.
Second thing is that you get regular follow-up. Every month you get your test done. If your tests are not doing well, every transplant patient understand how is my creatinine, how is my TLC, how is my TEC. They all learn in this period. Anytime you think things are not doing well, contact a doctor. Because if the rejection is picked up in early stage, it can be cured, it can be controlled, it can be taken care of. But if it is picked at a very late stage, then nothing can be done. So that is the third thing. Regular follow-up, taking the medicine regularly, be in touch with one of the doctors and keep taking care of your. Now that food is also, everybody asks this question. See, when we do transplant, what we are doing? We are giving immunosuppression to lower your immunity so that the kidney which has come from one of your relative is body accepted. So when we lower your immunity, you become more prone for infection. Because our body immunity prevents infection. There are thousands of bacteria, virus, parasites are all around. But our body takes care of. But when you become weak, like because of the immunosuppressive drug, when you become weak because of diabetes, when you become weak because of autoimmune disease, old age, poor nutrition, then you start getting all kinds of infection. So transplant patient, we always say, keep all your food, bring your food, cook at home, clean it like you bring the vegetables from market, wash it nicely, and then they can eat any food. They can eat, like if they have diabetes, there is some restriction, but otherwise they can bring any fruits, wash it, clean it, remove that, and they can eat it home. So we say it's a clean home cooked food. Second thing, it is unfortunate in most of the country, still the clean water is not available.
Not available, yes. Yes.
And if you don't drink clean water, you get diarrhea. If you get diarrhea, your TEC level will go up, your creatinine will go up. So clean, I always say very simple. You boil that water and then cool it and keep it in the bottle and drink it. It's very simple thing, you can do it. At least you may not be able to remove the impurities from the
germs,
but at least germs will be killed.
Gone.
So drink clean water or filtered water or boiled water if you cannot do anything, and home cooked clean food. And before you eat, or person who is making food should wash your hand with soap and water. Your utensils should be clean. Your cooking area should be clean. If you maintain good hygiene, there won't be any infection. And before you eat, you should wash your hand. You should keep your nail cut. So that if you take this simple precaution, which is not a very big deal to understand, you can avoid most of the gastrointestinal infection and water-related problem and diarrhea, dysentery and other things.
Doctor, before we pause for a very short break, I would ask you something, maybe something very personal. You being a healthcare professional for over 4 decades
45 years.
45 years. It's a long time. But we thank you for your service, and I'm sure you've done great good to humanity with your knowledge and your know-how. Sometimes people come the stage of maybe the kidney is gone. You see, when they come to you early, maybe you said that maybe we can control it, we can mitigate it. What if somebody comes to you and say, and you see that maybe it's too far, like it's gone too long now, Uh, where do you draw this line? Where can you intervene and where can't you
See,
intervene?
it's a very good question. See, if somebody is coming little late stage, what we have to do to stop the rejection is give anti-rejection treatment. And all anti-rejection treatment is going to further weaken your body immunity. And now some of the drugs are very strong. Your body immunity is gone and you are very prone for infection. You may not develop infection now, but maybe few months later, because some of times your plasma cells and B cells are knocked out for long period. Then you develop infection. So we might save your kidney, but you may die of infection few months later. So that is also not right. So we have to make a balance that how much anti-rejection we should give it without harming him, how much he can safely take it, and then we do the kidney biopsy and see how much damage has occurred. If the lot of damage has occurred, there is no point in saving this kidney.
Yeah.
But if there is not much damage has occurred, then we aggressively treat it, kidney reverse, and then they become better. So you have to make a balance that patient is not harmed, kidney is saved, and he may not develop too much of infection. So we don't over treatment. Over treatment, we have seen the rejection is taken care of, but patient died of infection.
Yes, infection.
So, but that is finally patient has died. So that is not good. So you have to take a balance in life. What is advantage, what is disadvantage, how much we are gaining, how much we are losing, and then you take a decision. And that's the job of a doctor to individualize the treatment. I know the doctor is not the God. He's not making decision for that. But with his all knowledge and experience, he decides that probably this is the best for this patient.
The best treatment.
He may be wrong, but he's taking a good decision for the favor of the patient.
We will get back after a very short break. Donc, moi, fais un appel à Bandimoun qui peut get nous en ce moment. 52 58 96 71. Si vous êtes capable, vous êtes en vie, téléphone-nous et pose quelques questions à Dr. Anant Kumar. Vous êtes la bienvenue. On a déjà un appel qui peut rentrer, mais nous passe une petite pause de pub et nous revenons de studio quelques minutes après.
Bienvenue dans le bureau Omka Eben. Nous accompagnons les patients dans un parcours médical. À Omka Eben, nous avons la facilité pour les patients et faire de réhabilitation. Alors, comment se retrouver là, nous en plein operation meeting qui nous fait chaque semaine.
Une filière, c'est un patient qui voyageait à l'extérieur et une autre filière, maintenant, c'est un patient à Maurice. Maintenant, un patient local qui est venu nous à Eben Office et ici, comment je trouve, nous avons une infrastructure qui nous est capable d'aider un patient en même temps de nous sur un soin localement. Et nous avons un infirmier, nous avons un équipement, nous avons un médicament qui nous est capable de proliférer un traitement localement. Et si le patient a besoin d'une institution médicale comme une clinique ou même un soin à domicile, ça aussi nous sommes capables de provide et nous sommes capables d'aider le patient.
Ici, nous avons l'équipe médicale et aviation coordinateur.
Donc chez Omka, nous believe très fortement dans le principe de l'innovation. Et vu que nous l'équipe très jeune, très dynamique, donc un des piliers de nos brands, c'est l'innovation en lui-même. C'est à cause de ça que toute solution qui nous fait dans tout département, les bases aux créativité et l'innovation.
Alors là, nous sommes au bureau Finance Officer et Human Resources. Bonjour Asna.
Bonjour, moi Asna Ramjan, Finance and HR Officer Omka Group, mon responsable pour gestion finance et ressources humaines.
Bureau Omka Eben, c'est très important dans nos écosystèmes. Nous avons patients, nous avons un service ici local, côté de la docteur, et nous avons l'équipe médicale, que tu peux guider un patient, comment il peut faire le traitement à l'extérieur, ou un medical evacuation, que toutes les choses en termes de healthcare qui passent directement dans le bureau Eben ici. Nous avons medical sport depuis grandir avec un docteur permanent qui est là. Nos foundations nous permettent un extraordinaire et les autres projets qui vont venir en temps de lieu.
Bienvenue dans les studios de Omka Santé Plus. Nous avons avec nous aujourd'hui un spécialiste, un sommité dans ce domaine, Dr. Anant Kumar, Chairman Urology, Renal Transplant, Robotics and Uro-Oncology de Max Saket. It's Max Saket.
Yeah.
You say that in India. Doctor, one question that we here at Omka Foundation, we do assist a lot of patients who are in financial distress to get a kidney transplant. You know, kidney transplant is not something that costs, it's not something cheap. It does cost a lot of money. Is India the same? Is it the same thing for the people of India? The cost factor and the financial burden maybe for...
Yeah, it's the same thing. Because in India, you know, there are around few people are very rich. Around 35 to 40% are of middle income
class
group, and then rest of the poor people. So around 30-40% people are poor. Fortunately, nowadays there is some financial help is available. Like there is Ayushman scheme by the government of India, 5 lakhs of rupees government insurance has given to every citizen who are poor.
Yeah.
And then a lot of people have taken medical insurance. People also get help from the various foundation.
Yes.
And the chief minister fund, like chief minister fund of every state gives 3 lakhs, 4 lakhs. Prime minister fund, people get 1.5, 2 lakhs. So they arrange fund, and sometimes they arrange fund by crowdfunding.
Yes.
And some various foundation also help. And such when we understand that patient is poor, we also help them in cutting the hospital costs, providing some medicine from the companies. Company also provides free medicine for few months, and hospital will cut down the cost. So we try to help them. And I always tell all my patients in India are not been able to take the medicine because of the cost factor. Come to us, don't feel helpless, because there are a lot of, at least 25 Indian companies are making immunosuppressive drugs. So when we call them, 2-3 companies, so they come forward, they provide medicine at least 1 month, some will give 2 months, sometimes 3 weeks. So at least now you have a medicine for 2-3 months. So, and meanwhile he will organize finances for future. So we do tell that medicine, the company which has given you maximum medicine, buy medicine when you have funds for that, because that will help that company also.
Living true to the sermon of
somebody's help. So that way we try to help the people, because I have seen that patient arrange fund, they loan their ornaments, they loan their, they keep their house as a mortgage, and get the fund to get it done. But that journey doesn't stop there. You have to keep taking immunosuppression throughout the life. Initial few months cost of immunosuppression and investigations and care is more. But as the time passes, it becomes very reasonable. And those who are poor, we don't give expensive medicine. Like we give them Ajoran, not the mycophenolate. We give them cyclosporin, not the tacrolimus. So we give them... and that a lot of Indian companies' drugs are at least 1/3 cost of the drugs which are made by the international company. So patients are being able to afford treatment, and but still sometimes I get patient who lost that kidney because he said I did not have money to take the medicine, or I did not take medicine for 2 weeks. I forgot, or I missed it. I was somewhere where medicine is not available, and I could not get it. So all those reason is for the rejection. But it's very good if there is a foundation, if there is a government support, or if there is something. And you know, in India, there is all the company, they have to do something like CSR.
Yeah.
They have a community support.
You need to support the
So-
community.
So,
Same thing that
so
we have.
they do help. If you just talk to them, they will provide some help.
They will provide some help. I think that Umka Foundation does here in Mauritius. People coming to us with with 0 rupees, and they are sick. They need to get treatment done. This is what we do here. We get the funds for them. We arrange for that, and then we send them to you to get a treatment in India. You know your your Minister of Foreign Affairs is in Mauritius right now.
Jai Shankar.
Jai Shankar.
He's a very good man, very smart
He's
guy.
a very smart guy.
And he's very knowledgeable and very balanced
smart,
person.
yes, very diplomatic person. And he's in Mauritius right now. They inaugurated a renal transplant unit in Mauritius. He inaugurated that. It's the first that we have. You know the first renal transplant when was done in Mauritius?
No, I have no idea.
In 1982. In 1982, we had the first renal transplant, kidney transplant done in Mauritius. And then it stopped for several years because we didn't have specialists to do that. Now it's coming back again. And hopefully with the help of India and your government, maybe we can establish some. But since this government took very good job that you did for Mauritius, like Jai Shankar and his Prime Minister doing very good job for Mauritius. So we talk about kidney transplant, we talk about robotic and uro-oncology. Those one thing you wanted to talk about also in international patient that we have this vascovaginal fistula.
Yeah. Two things I will say. One is that in Africa especially, in some of the countries, very good obstetric care is not available. The pregnant women, they go into obstructed labor and then they are not properly treated. They should immediately undergo cesarean section. But they are in the prolonged labor. So that leads to development of vascovaginal fistulae. And those fistulae are big and very bad. And not all country in that region have experts to take care of them. There are many good surgeons available in Africa to do this job, but not everywhere. And then they are operated and they are not well, and then they come after 2-3. Every failure, like if it is the first time, results are good if a proper operation is done. But if it has failed and now you are getting a patient after 3 times failure, because local tissue is not good. You have to reconstruct from the local tissue. So the operation become a big challenge. And we get such patients. Nowadays we are doing these operation with the robot, and I'm very surprised to see the outcome. With the help of robot, with minimally invasive, we are producing very good results. So, and also I have seen that there's many part of the Africa is still want on. There's a lot of unrest, lot of fighting going on. In Middle East, lot of fighting is going on.
War is on there.
And there's this war is everywhere. So we get patient with because of the war injuries, and their bladder is disrupted, urethra is disrupted. They are not properly taken care of. They are leaking urine, and when they come to us, and there is no immediate solution. You have to divert the urine, you have to do SPC, then we have to wait some time. And then when the tissue become good, then you do first operation, second operation.
It's a long
and
process.
They don't have so much of money because they have to stay in the hotel, they have to go back. So it's a big challenge.
It's
but
a huge challenge.
We have done many good reconstruction, and these are the very challenging case, and our unit is very specialized in taking care of very bad stricture urethras, very bad urinary fistulas, very bad war injuries. And when you take such challenging case and you work whole day and then patient becomes all right, he says thank you before going, you feel very satisfied.
You get this.
These are the very complex surgery.
Yeah.
And they give lot of satisfaction that at least you help somebody.
Yeah. Not just you help somebody, but mission accomplished. As a doctor, as a healthcare professional, when you go home, maybe you get this feeling, yes, I've done my job right. Doctor, now it's time for us to talk about Max Super Speciality Hospital. How many beds?
See, Max they have almost 24 hospitals all over the country. And all are the major hospitals. They are mainly in Delhi, but they are also in Mumbai, Bhubaneswar, and Chandigarh, and
Pan India.
other country. And they are the fast growing companies in healthcare. They are probably growing all over the country. Next few years, they'll be everywhere. One good thing is that they have a good infrastructure and they have good doctors. See, it is not that building or the machine which makes the difference. Is the good doctors make the difference.
Definitely.
So if you have a good doctors and a single good doctor cannot do good work. He needs to have support of the other colleagues. Like I need support of the cardiologist, nephrologist, gastroenterologist, neurologist. I need support of our good nurses, good technicians, good lab support, good intensive care support. When we get very complicated patient, why we excel is because we have a good multi-specialty and good ICU care. Patients are there, they are seen by, sometimes one patient is seen by 12, 13 doctors.
Yes, at the same time.
And everybody is doing his job. Then we do MDT. We like multidisciplinary meeting. When after 2-3 days, when all the investigation done, we meet all the doctors and then we discuss and we take each other's opinion. We listen to each other. Then we make a plan that we should go in such a way so that the team provides the better result than one individual person. So it's the team, it's the multi-specialty, good intensive care, good lab support, good radiology support, good imaging facility, and good doctors in all specialties. That helps us in excelling and doing better job than others. So I don't say even if very single good doctor may not do very well because he needs support of everybody.
Of course.
I have done a good operation. If nurses has not taken care of that, then
It fail.
it will fail.
It will fail.
So then, but we have a problem of nurses because we have nurses, they come for 2-3 years and they are working there, immediately get a job in Middle East or in other countries
yes.
and they get better salary and then they leave and then we'll have to retrain. So this cycle is going on.
Yes,
again and
keep on
again.
going. How important is it to have good, like, different verticals in you being the chairman of this department?
Yes, it's very important that, see, every brick in a house is important. Some are very important, like support one.
Yeah.
But so everybody's contribution, like if the cleaning person is not doing cleaning, the infection rate will go up. If your sterilization is not good, then your infection rate will go up. And that will take care of, it will bring down your results. If your nursing care is not good, your imaging, your reports are not good, your imaging is not good, and they are not prompt, then you'll have problems. So in hospital, that's why multi-specialty hospitals with good supports is very important for the best care. That's what the Max is. They have multi-specialties, they have very good doctors, they hire very good doctors, they provide good infrastructure, they provide good support. And then they look after their doctors. And when we go with the problem that we need this machine and all that, they procure it. So we have now, we say that our hospitals are as good as any other American hospital.
Yeah.
Like if any new machine comes up in America, it will be here within 6 to 1 month, 1 year or something. And once we know that, yes, that one is working well, it's good, we should have it. Then
They
we
test them and then
so that's help us in providing good care.
Good care. Doctor, thank you very much. Before you go, one last question coming from one of our viewers asking for a 4-year-old girl having early nephrotic syndrome.
Yeah.
She swells a lot. She is currently under treatment of cortisol. She does have those episodes of being moody sometime, and she is she doesn't want to eat. She can't eat properly. She doesn't want to eat. Doesn't want to be fed. They've stopped salty food. no snacks with salts and everything, what would you advise them?
See, the nephrotic syndrome usually seen in children. And what happens? See, our kidney is very efficient. It's working all the time, whether you are sleeping, working, doing anything. Each kidney have millions of small dialysis unit, and we call it nephron.
Nephron.
So when the blood comes, they filter it, throw the waste part, and keep the good part. In nephrotic syndrome, what happens? The pores of the filter becomes bigger.
Bigger, yeah.
So they start losing good thing also. They start losing protein. When the protein is going in massive amount in the urine, your body will swell up because protein is the maintain the oncological pressure inside the vessels. Oncotic pressure. So oncotic pressure is osmotic pressure is maintained so that fluid stays in intravascular compartment. Now what happens? Because the protein has lost, all the fluid leaks out and then you are swollen up. When you are swollen up, then all the cells are not working well. Because they are like if you have no space to expand, no space to work, how will you work? And then the treatment is by cortisol, which leads to mood swing. Most of the patients recover with the good treatment. Nowadays, it's not only cortisol, various like immunosuppression drugs are also used. Some of the monoclonal antibodies are also used. Those who do not recover are those who do not recover are those who get recurrent attack and finally kidneys damaged, they will need kidney transplant. But those who will recover will go well. Why they don't like to eat is that their whole body is swollen, so they don't have a good appetite. Plus, there is some dietary restriction also, less salt, and their cholesterol is also high, a lot of other things. So, food is tailored to so that they can digest that food and that can take care of it. And the children's, they can't eat everything. They like to eat few things. So that's the reason is, but most of the children with the treatment, they do recover.
We do have someone who wrote to us, Varuna. I don't know if you know her. She says, Anand sir, did our transplant in Max Saket, Delhi in January 2025. And all we can say, he got a magical hand. He gave my husband a second life. And today we have the privilege to meet him. There's somebody who's been watching you, maybe one of your patients, saying that. And we do have another one, Nosad, who said the doctor is speaking the truth. I am actually under treatment through OMCA, and the fact he just said is many doctors are involved in your treatment is true. Taking care of all Mauritian patients coming to India for treatment. So you're very well known about the among the Mauritian patients.
I have done a lot of patient transplant in Mauritius, a lot of patients in Africa. Now it's very interesting. Some of the time these patients from these countries, especially from the Middle East and Central Asia, they like somebody has gone back. And so before they go, they click a photo. Then they give that photo. They come and match, and then they confirm. Oh, this is the doctor.
This is the doctor. So you will be very much more famous. You've been on OMCA Santé Plus, doctor. I won't keep you for long. I know that you have a CME and that you will be taken as from 2:00. So you do have less than 50 minutes before you reach your next destination. It was a huge honor to have you here, doctor.
Thank you.
And keep on doing this wonderful job that you are doing. And when you come back again later, maybe when I'll come to India, I will come to meet you, and then we'll do another show.
And I must say that together. OMCA is doing very good job, and I'm very much impressed that you are also providing support to the patient to get the treatment. That's a very good humanitarian support you provide, because some of the patients really need it. And it's a good thing is that guiding the patient to get the right treatment. And because that is missing. People don't know where to go, whom to contact, what to do, even if they have money. So the proper guidance, proper arrangement, proper things helps the patient that take care of their anxiety.
Yes.
They know that somebody is helping us.
Yes.
Somebody is there
So
to meet me there.
They can concentrate only on getting better.
So you're thank you for doing such excellent work. Keep doing it.
Thank you,
and
Doctor.
God bless you.
Thank you for having been with us this morning in our studio. Thank you. I will let you go. We say thank you to, you can say to the camera here, thank you to everyone watching us. Merci de nous avoir suivis sur OMCA Foundation, sur OMCA Santé Plus et OMCA Overseas Medical Care Assistance Limited. C'était le docteur Anant Kumar de Max Super Speciality Hospital, Saket, New Delhi, India. Donc le chairman en urologie, Renal Transplant, Robotics and Uro-Oncology. Vous avez l'occasion de regarder ça l'émission là, sur YouTube. Vous êtes capable de downloader, like, share. Et il y a beaucoup de gens qui souffrent de ce problème qui nous cause aujourd'hui là. Donc, et nous cause le problème les reins, nous cause le problème cancer. Donc, vous êtes capable de regarder l'émission et nous pouvons faire un plaisir de rediriger vers Dr. Anant Kumar. Merci beaucoup. À très bientôt. Passez un bon week-end. Bye bye.